Okay, I hope some of you are coming back and rejoining us for the second session. This is an oral abstract session, and I will hand over the reins to Amy Arnold and Kate Bourne in just a moment. Before I do, just a couple of housekeeping messages, two specifically. One, some of you have been involved in the UCNS board review course that is sponsored by the American Autonomic Society and led by Dr. David Goldstein. He wanted us to either remind you or tell you, if you didn't know, that the next session will be this coming Sunday, I believe at the usual time. So if you have been attending, please do plan to attend. This is leading up to the big finish. As you know, the exam is coming up in a few weeks. Housekeeping announcement number two is we did have some issues in the last session with people being kicked out of the Zoom link through the Wova app. We have contacted Wova. They first blamed several other things. And when Amber reassured them that we were doing those things properly, they eventually said, yeah, we have something called an SDK problem with Zoom, which is an interconnectivity problem, but we are assured now that it has been resolved. Having said that, if this happens again, please email me or Amber and we will send you an alternate link to get back into the session. We don't want you to miss this content. And finally, some people had questions that they were asking as we were closing out the sessions. Once we do that, it's tough for us to see those questions, or even if we can see them, tough to get them answered in real time, although they can be answered afterwards asynchronously. If questions are coming up, please start typing quickly. Most of us can speak faster than we can type, so it takes a little more time to type them. So start earlier. We do want to get to your questions if we have a chance to do so. And with that, I will hand the reins back to Amy and Kate.
Thanks, Satish, and good morning to everyone. Thank you for joining us for the oral abstract session A. My name is Amy Arnold. I will serve as your chair for this session. I'm an assistant professor of neural and behavioral sciences at the Penn State College of Medicine. I'm joined by my co-chair, Kate Bourne, who is a doctoral student in the laboratory of Dr. Satish Raj at the University of Calgary. We have put together an exciting research-based session for you today with talks from both early stage and established investigators that were chosen from our top ranked abstracts. We'll first have 3 10-minute oral abstract presentations, which are each followed by 5 minutes for questions and answers. And then we'll have 5-minute lightning abstract presentations. So these are shorter presentations to give a broad overview of projects and hopefully get more people able to present and share their research. There will be a panel discussion session at the end of all of those 5 lightning round abstracts. Before we begin, we would like to thank our sponsors, Theravance Biopharma, Lundbeck, the MSA Coalition, and Biohaven Pharmaceuticals. We would also like to thank our exhibitors, Biohaven Pharmaceuticals, Phenopress Medical Systems, Lundbeck, the MSA Coalition, Theravance Biopharma, and WR Medical Electronics. Please remember to visit their sites, as well as our virtual poster session at the end of these sessions. And without further ado, I'll go ahead and introduce our first speaker. So the first speaker is Tatiana Coverdell from Charlottesville, Virginia, and she'll be presenting an abstract entitled Control of Heart Function by Nucleus Ambiguous Neurons.
All right. Can everyone see my screen? Good. Okay, so thank you for that introduction. I'm really excited to be here at AAS this year. And today I'll be talking about the control of heart rate by nucleus ambiguous neurons. So heart rate is a major indicator of cardiovascular health, both in the context of everyday living as well as disease. And resting heart rate is a commonly used metric for assessing how fit a person is. But even furthermore, in the context of cardiovascular disease, there have been a lot of studies looking at the relationship between resting heart rate and disease or mortality risk. So one study found that as resting heart rate increased, so did the risk of overall mortality. Even furthermore, as resting heart rate increases, so does the risk of myocardial infarction. So we can see that heart rate is hugely important in the context of health and disease. And not only is heart rate an important metric for health, but heart rate variation is as well. And this refers to the variation in time interval between consecutive heartbeats. In a healthy heart, there should be some variation between each beat. And this variation in heartbeats all comes back to the interplay between parasympathetic and sympathetic nervous systems. So what we know from resting heart rate and heart rate variability studies is that parasympathetic input is actually super important. So low levels of parasympathetic cardiac activity are associated with cardiovascular diseases such as hypertension, sudden cardiac death, and heart failure. And parasympathetic control of the heart is actually mediated by what are called cardiac vagal preganglionic neurons, or CVNs, which project from a region in the hindbrain called the nucleus ambiguus to the heart via the vagus nerve. And stimulation of the vagus nerve and the nucleus ambiguus has been shown to reduce heart rate, whereas lesioning of the nucleus ambiguus actually results in an increase in heart rate. In addition, the nucleus ambiguus has been shown to also control atrioventricular conductance and ventricular contractility and excitability. So clearly, CVNs in the nucleus ambiguus play a vital role in heart function. So it's great that we have this information about CVNs, but despite knowing this, research has actually been pretty limited in the past due to its inability to actually access the CVNs. And this has been difficult because embedded in the nucleus ambiguus, along with the CVNs, are a lot of other neurons that innervate and control different things. So retrograde tracing studies have shown that nucleus ambiguous neurons innervate the larynx, pharynx, esophagus, trachea, and lungs, in addition to the heart, controlling a broad range of functions, including swallowing, aspects of speech, and breathing. So limited tools and methodologies have made it difficult to determine the molecular, anatomical, and functional organization of these neurons within the nucleus ambiguus. So we use single nuclei RNA sequencing to overcome this. And this method allowed us to profile genome-wide RNA expression in individual nuclei. And what we found was that our sequencing of the nucleus ambiguus revealed 3 clusters of cells. And we were able to actually look at the topmost highly variable genes in each cluster and determine marker genes for each cluster that we could then use in the future to identify the cluster. And this was based on a high level of expression and specificity in the cluster. So you can see here in this figure, kind of towards the right, we have our 3 clusters marked by the genes CRHR2 for 1, VIPR2, and TBX3. So given the importance of this region in cardiac function and the differences in functions that it controls, this led us to basically ask which nucleus ambiguous neuronal subtypes are CVNs. And specifically to answer that question, we're asking a couple other questions, which is which subtypes innervate the heart and which of those subtypes control heart rate. So we performed RNA fluorescence in situ hybridization studies, looking at each of our cluster markers and the gene chat, which marks all nucleus ambiguous neurons. And we found that each subtype marker was located in distinct subregions within the nucleus ambiguous. And what's interesting about this is that previous retrograde tracing studies have indicated that neurons in different subregions of the nucleus ambiguous project to different organs, suggesting an anatomical and functional organization of the nucleus ambiguous. So the marker CRHR2 was found predominantly in the rostral compact nucleus ambiguous, as shown on this left panel. And we also found that this marker co-localized with the gene CALSA, which is a marker of striated muscle motor neurons and marks airway and upper digestive organs. Our TBX3 nucleus ambiguous neurons, also marked by the gene ADCYAP1, were found in the mid semi-compact nucleus ambiguous. And our VIPR2 nucleus ambiguous neurons were found in the caudal loose nucleus ambiguous, shown on this right panel. So taken together, this strengthened our hypothesis that each cluster is distinct from each other. And it also gave us more clues as to which organs each subtype might innervate. So we also wanted to see which organs each subtype innervated. So for the sake of this talk, I'll just focus on the TBX3 nucleus ambiguous neurons. So we labeled TBX3 nucleus ambiguous neurons by injecting a Cre recombinase dependent TD tomato fluorescent protein. And then we waited for adequate expression and then harvested the heart and brain from these mice. And from here, we were able to optically clear the heart and then image it using confocal imaging. So this left panel of the figure is showing the nucleus ambiguous injection site, where all nucleus ambiguous neurons are labeled by chat. And here we're showing that co-localization of some of these TBX3 TD tomato neurons with chat confirmed that we did indeed label these neurons with TD tomato. And on the right is an image of the heart from these mice, where we can see TD tomato positive axons in the heart. And in essence, what we found here was that these TBX3 neurons innervate multiple cardiac sites, both in the atria and the ventricle. And lastly, we wanted to explore the physiological functions of our subtypes. So we used an intersectional optogenetics approach to activate our nucleus ambiguous subtypes. And then we recorded heart rate before, during, and after activation. And to do this, we used intersectional genetics to express light-activated channel rhodopsin in each of our nucleus ambiguous subtypes. And then we implanted an optic fiber above the nucleus ambiguous as well as a head stage that allowed us to record the EKG in conscious mice, which eliminated any confounding effects of anesthesia on heart rate and respiration. And we were then able to optogenetically activate these neurons and record the EKG. So here on the bottom left is a figure from one of our recordings in which we activated TBX3 nucleus ambiguous neurons. And what we found was that heart rate, which was about 500 beats per minute at rest, rapidly and dramatically decreased when the laser was turned on, and then quickly recovered once the laser was turned off. On the contrary, when we did the same experiment activating VIPR2 nucleus ambiguous neurons, we saw basically no change in heart rate, suggesting that TBX3 nucleus ambiguous neurons, but not VIPR2 nucleus ambiguous neurons, actually reduce heart rate. So in conclusion, what we found is that single nuclei RNA sequencing has revealed 3 molecularly distinct neuronal subtypes in the nucleus ambiguous, and that our TBX3 nucleus ambiguous neurons innervate multiple cardiac sites. We also found that activation of TBX3 nucleus ambiguous neurons reduces heart rate, but activation of VIPR2 nucleus ambiguous neurons does not affect heart rate. And with that, I'd like to thank everyone who has contributed to this project. So my PI, John Campbell, as well as Patrice Guynet, Ruth Stornetta, Steve Abbott, who did a lot of the optogenetic experiments with me, and Ray-Jen Abraham Fan. And then I'd also like to acknowledge our funding. So UVA's 3 Cavaliers seed fund, as well as an NIH Pharmacology Sciences training grant. And with that, I'll open the floor for any questions.
Okay, it looks like we have a question from Patrick Muller. Did you try transfecting left versus right nucleus accumbens neurons and look at effects on heart rate?
So we predominantly just focus on the right nucleus ambiguous because a lot of previous studies have suggested that this has more of an effect on heart rate. But that's something that we can definitely do is compare left versus right. I think that'd be really interesting.
I'll ask a quick question while we're waiting to see if things trickle in. I may have missed this, but you focused on kind of the efferent output from the nucleus ambiguous to the organs. Is the incoming or afferent input to those neuronal subtypes similar from the NTS, I assume?
Yeah, so to look at the afferent inputs, we'd have to look at the NTS. That there aren't really any afferent inputs to the nucleus ambiguous. So we were just focused predominantly on efferent output.
Would you anticipate that even coming from the NTS, there'd be different kind of inputs to each of these subtypes? Or do you think it'd be the same?
I would assume that there are different inputs to each subtype. And that's actually something that we've considered doing in the future is using rabies mapping to actually look at inputs to each of our subtypes. And I'd imagine that we'd see pretty distinct inputs as well.
Okay, we have another question. It says, I assume you have planned halorhodopsin studies to look at endogenous control of heart rate. Any insights?
We have actually not. Sorry, are you asking like inhibition studies?
Yes.
So that's something that we are going to do in the future, but we have not done that yet. So it'd be interesting to kind of look at the flip side of basically deactivating or inhibiting these neurons and seeing the effect on heart rate. So we have a couple ideas of either using optogenetics to do that, or we can actually ablate nucleus ambiguous neurons and then look at the effect as well. But we have not done that yet.
Okay, we got a question through the chat. Did I see that your nucleus ambiguous neurons inner are the ventricles?
Innervate the ventricles, yes.
Yes, probably. Thank you.
Yes. Yeah, so they did actually. And that's something that we were pretty excited to see, because I think the current field of thought was that innervation was predominantly in the atria. But there's actually been a few studies suggesting that the nucleus ambiguous innervates the ventricles as well. So that was pretty cool to see. It's a good question.
Great. I think we're all out of questions. Thank you, Tatiana, for that great talk. And we'll move on to the next presentation.
All right, so the next presentation we'll have here is by Dr. Risa Isanaka, and the title of her talk is Pathophysiological Meaning of Alpha-Synuclein Deposition in Sympathetic Noradrenergic Nerves in Skin, Submandibular Gland, and Heart.
Thank you. I'll share screen. Everybody seen the screen? Okay. Good morning and good afternoon, everyone. Thank you for the opportunity to present our research today. Lewy bodies are the histopathophysiological hallmark of Parkinson's disease, or PD. In 1997, it was discovered that Lewy bodies contain the protein alpha-synuclein. Since then, the concept has emerged that PD is a synucleinopathy. Alpha-synuclein can also be deposited in neuronal fibers, which are called Lewy neurites. Here is a Lewy neurite, in which alpha-synuclein is deposited inside a nerve fiber that contains tyrosine hydroxylase, TH. TH is the marker of catecholaminergic neurons. PD is well known to be a catecholamine-related disorder. There is drastic depletion of the catecholamine, dopamine, in the putamen in PD. This is what causes the movement disorder. PD also involves a loss of the closely catecholamine norepinephrine in the heart. Norepinephrine is the main chemical messenger in the sympathetic nerves in the heart. Here is the images of the heart using the sympathetic neuroimaging agent 18F-fluorodopamine. As you see, there is obviously decreased radioactivity in the heart in the PD patient. This means the PD patient has severe cardiac noradrenergic deficiency. This brings up a key question. What is the pathophysiological significance of intraneuronal alpha-synuclein deposition in catecholaminergic neurons? In this postmortem study, we addressed this issue directly. We measured norepinephrine, immunoreactive alpha-synuclein, and also tyrosine hydroxylase in 3 different tissues: myocardial, submandibular gland, and scalp skin, from the same patients with autopsy-proven PD and control subjects. If intraneuronal alpha-synuclein deposition were pathogenic, then both norepinephrine and tyrosine hydroxylase would be decreased in the PD group. This slide shows post-mortem submandibular gland from a control subject in a PD patient. Red shows tyrosine hydroxylase, TH. Green is alpha-synuclein. Blue shows smooth muscle actin, and yellow shows co-localization of TH with alpha-synuclein. You can see a lot of green and yellow in the PD patient, but not in the control. This slide shows post-mortem scalp skin from a control patient, from a control subject and a PD patient. Similarly, there is co-localized of alpha-synuclein with TH in the PD patient, but not in the control. This slide shows post-mortem myocardial tissue from a control subject in a PD patient. In these images, blue shows cardiac troponin T. The PD patient has decreased TH, and there are both green and yellow fibers, but not in the control. Here, we see the individual data for alpha-synuclein signal intensities in myocardium, submandibular gland, and scalp skin. In the PD group, there is increased alpha-synuclein deposition compared to the control in all 3 tissues. Here are the individual data for tyrosine hydroxylase, TH signal intensities in myocardium, submandibular gland, and scalp skin. In the PD group, myocardial TH is moderately decreased from the control, while in the same patients, TH is not decreased in submandibular gland or in scalp skin. Here, we see the individual data for norepinephrine in myocardium, submandibular gland, and scalp skin. In the PD group, myocardial norepinephrine is severely decreased from the control, while in the same patients, norepinephrine is not decreased in submandibular gland or in scalp skin. Conclusions. In PD, intraneuronal alpha-synuclein deposition in submandibular gland and scalp skin does not seem to be pathogenic, since both norepinephrine and tyrosine hydroxylase in the same samples do not differ from the controls. In contrast, in the same PD patients, myocardial TH is moderately decreased, and norepinephrine is drastically decreased. These findings suggested that in PD, sympathetic nerve in the heart are more vulnerable than sympathetic nerve in other organs. My colleague Guillaume Lomat will be talking about this topic a little later. Thank you for your attention. I'll stop share the screen.
And thank you, Dr. Isanaka, for that very interesting talk. And we'll turn it over now to questions. I don't see any yet in the chat, so I'll just start with one. And it's sort of a broad question, but I'm just wondering with these interesting findings, sort of what your next step will be with this work.
Next step, it's a good question. We need to think about it. Now we are thinking and investigated what exactly alpha-synuclein does to the neurons. So we have a collaboration study with our NIH, and they brings up the genotypic abnormalities patient sample, so we can compare if the patient has a synuclein gene problem, should be a positive control, and other sporadic PD patient. So
Okay.
we'll see.
Awesome, yes. Okay, and now there's a question here in the chat. Did you biopsy internal or external submandibular gland?
What's the question? Internal submandibular?
Yes.
Yes.
Internal or external?
I think internal.
Okay. And there's another question here. What type of alpha-synuclein antibody was used? Was it targeting phosphorylated alpha-synuclein or general alpha-synuclein, i.e. non-pathogenic or pathologic?
Okay, thank you. I use the total synuclein, alpha-synuclein.
Okay. And then one more question here. Do you think the level or pattern of sympathetic activity in the heart versus skin or submandibular might contribute to the selective sensitivity of cardiac nerves?
Yes, we think something special in the heart, but maybe Guillaume will be talking about it. I'll leave it to him.
Okay, awesome. Thank you so much. I think that's all the questions that I can see. So I think we can, one more question. Can you stain for DBH as well?
Yes, I've tried it before, yes.
Okay. Great. Yeah, so I think we're ready to move on to the next talk, unless I've missed any of the questions.
Thank you.
Thank you. Oh, there
is one more question in WuvaHat that may be interesting. Dr. Freeman is asking, is there any possibility that the results could reflect technical issues or differences related to looking at 3 different tissues, submandibular gland, skin, and myocardium?
What's the question?
Is there any possibility that your results could reflect technical issue?
We do 2 different persons have done this study. One person did the immunofluorescence, I did, and the other, my colleague Patty, was done for the catechol. So we are unbiased. We all assayed the cold samples until we tabulate the result. So I don't think it's a technical problem with there.
That's good.
Thank you.
Okay, thank you. One more question. What happened with the DBH in PD?
That's processing now. I hope we'll be presenting next time.
Okay, great.
Okay, we're going to move on to our third oral abstract presentation. This one is by Brooke Schaefer from Kelowna, BC, Canada, and it is entitled Muscle Metaboreflex Control of Sympathetic Activity is Preserved in Healthy Males Following Acute Intermittent Hypercapnic Hypoxia.
Great, thank you so much. Let me go ahead and share my screen here. Right. Everybody can see this so far? Great. Great, yes, thank you so much for having me here this morning, my time, afternoon, I think, for other people across the country. So I'm a third-year PhD student, and I'm happy to present some of the data we have. So cardiovascular and ventilatory adjustments to exercise are initiated through central command and afferent fibers arising from contracting skeletal muscle. And these include group 3 mechanoreceptors, known as the mechanoreflex, and group 4 metaboreceptors, known as the metaboreflex. And so together, all of these initiate an increase in sympathetic activity, blood pressure, and heart rate during exercise. And this increase in pressure is maintained because of an upward resetting of the baroreflex. And so we can isolate the metabolic component of this exercise-induced pressure response through post-exercise circulatory occlusion, or PICO. And so here we have our subject performing a submaximal bout of isometric hand grip exercise. And after a few minutes, we inflate a blood pressure cuff to trap those metabolites that continue to stimulate the metaboreflex. Once the subject has stopped exercising, then we remove the influence of central command and mechanoreflex while the metaboreflex is still sending that afferent information. So during this PICO period, we have a continued resetting of the baroreflex that allows for sympathetic activity and blood pressure to remain elevated while heart rate returns towards baseline levels. So recent evidence suggests that this metaboreflex control of sympathetic nerve activity is impaired in patients with obstructive sleep apnea. So here we have middle-aged patients who are overweight and obese looking at this metabolic component. And so at baseline, we see that our patients with obstructive sleep apnea have elevated levels of muscle sympathetic nerve activity. And that during hand grip exercise, there's this augmented sympathetic response. But contrary to what we would expect during this PICO phase, when we would expect sympathetic activity to remain elevated, in our patients, it starts to decrease towards baseline levels. And there's no real group differences in blood pressure between these two groups with this test. And so airway obstructions that are associated with obstructive sleep apnea result in intermittent hypercapnic hypoxia. And this increases overall sympathetic vasomotor outflow. So again, these subjects in this study were middle-aged, overweight, and obese. And so how exactly these alterations in blood gases affect the metaboreflex activation, independent of cardiovascular morbidities, remains to be determined. So we sought to investigate the influence of acute intermittent hypercapnic hypoxia on sympathetic and blood pressure responses to hand grip exercise and muscle metaboreflex activation in healthy men. So we hypothesized that following our acute IHH stimulus, resting sympathetic activity and blood pressure would be elevated. We would see an augmented sympathetic response to hand grip exercise, but that we would see an attenuated sympathetic and blood pressure response during our muscle metaboreflex activation. So after providing informed consent and clearing all pre-screening assessments, subjects were invited to come back for our experimental protocol. So first, we gave ourselves about 60 minutes to get the subject instrumented and get an appropriate muscle sympathetic nerve signal. This is what our setup looked like. We had automated blood pressure cuff for blood pressure readings, our hand grip dynamometer for our hand grip exercise, microneurography for our muscle sympathetic nerve recordings, finger photoplethysmography for beat by beat blood pressure, heart rate, stroke volume, and cardiac output measures, our face mask and pneumotac for our ventilatory variables and end tidal O2 and CO2, our ECG, and then our pulse oximetry for oxygen saturation. And so after setup and we had a clear signal, we had 10 minutes of baseline measurements, and then we went into our metaboreflex protocol. And this consisted of 2 minutes of isometric hand grip exercise at 30% of the subject's maximal voluntary contraction, followed by 4 minutes of our PICO, which was, we inflated that blood pressure cuff to 250 millimeters of mercury. Following that, subjects underwent 40 minutes of our intermittent hypercapnic hypoxia exposure, and then we repeated our baseline measurements and our MMA testing. So as we can see, our subjects were young, normal BMI, no evidence of sleep disordered breathing or any sort of dysfunctional lung function. And this is our baseline measurements pre and post IHH. So we can see that our ventilation is increased following IHH. And this is due to an increase in breathing frequency. Tidal volume was unaffected. We have a significant increase in diastolic blood pressure and our mean arterial pressure. And heart rate was trending towards significance, but didn't quite reach that higher level post IHH. But following our stimulus, all of our sympathetic variables, burst frequency, burst incidence, burst amplitude, and total activity were significantly elevated at baseline following IHH. And so here we have our heart rate, mean arterial blood pressure, and our total MSNA response throughout the entire protocol. And at baseline, we see heart rate is slightly elevated, but not quite significant. Mean arterial pressure elevated and total activity is elevated. During hand grip exercise, no difference in heart rate pre or post IH. And then we have an increase in our pressure and then increase in total activity. And then during our PICO phase, heart rate appears to be elevated, didn't quite reach significance, but we do have our increase in mean arterial pressure and total activity following IHH represented here in the triangles. So using mixed effects linear models, we then compared baseline pre and post to our hand grip minutes and our PICO minutes pre and post. And so here on the left, we see our absolute data represented in a box plot. We have the bottom whisker representing the minimum value, top whisker representing the maximum value, the bottom of the box being the first quartile, the top being the third, and then this thick bar here being the median of the data with the individual data plotted on top. So left is our absolute responses, and then on the right, we have our change data in our bar chart. And so this is change from baseline. And so as before, we see that mean arterial pressure is significantly elevated post IHH in our dark gray box compared to the pre, the light gray box. But that the difference in MAP with our first hand grip minute is not different pre or post, and there's no difference in the change in pressure with hand grip minute 1. Hand grip minute 2, we do see that MAP is significantly increased compared to pre in our second minute, but that change in mean arterial pressure from baseline is no different between pre and post. So overall, no effect of IHH on MAP response to exercise. Now looking at our total activity, similar as before, we see total activity significantly increased, and it is significantly increased in our first minute of hand grip exercise, but no difference in that change from baseline in total activity. And similar to mean arterial pressure, we do see that at hand grip minute 2, sympathetic activity is significantly increased post compared to pre, but that this change in overall total activity from baseline is no different pre and post. So again, no effect of IHH on total MSNA response to hand grip exercise. Now we're looking at each minute of PICO compared to our baseline data. So again, mean arterial pressure significantly elevated following IHH, and it is significantly elevated for our PICO, for our first minute of PICO compared to our first minute of PICO pre, but that this change in pressure is not different pre or post. And then similarly for minute 2, absolute data, absolute value is elevated, but no difference in the change from baseline, similar to minute 3, and same for minute 4. However, when we look at all 4 minutes of PICO combined, there is a significant increase in MAP following IHH compared to pre. So overall, there was a modest increase in MAP during PICO post IHH. And then finally, with our total activity, we have a significant increase in total activity following IHH, and this is significantly elevated during our first minute of PICO compared to pre for the absolute data. No difference in the change in total activity from baseline. Same with minute 2, same with minute 3, and same with minute 4. So there was no effect on IHH on total MSNA response to our PICO stimulus. So in conclusion, IHH led to sympathoexcitation and increased MAP without affecting the pressor response to exercise. The sympathetic response to metaboreflex activation during PICO was preserved with a slightly augmented pressor response. And contrary to our hypothesis, these data would suggest that in healthy men, acute IHH does not alter muscle metaboreflex control of sympathetic activity. And so with that, I'd like to acknowledge my advisor, Dr. Glenn Foster, and some of our co-authors. We worked with the University of Guelph, and so Dr. Phil Miller and their team, and then our fundraising, or sorry, our funding grants, and then that's the team. And that's all I have.
Great, thank you so much. We'll open this up to questions. We already have a few that have trickled in.
Great.
Let's see. First, we'll go to, have you considered to perform a sham or a control session?
Yep, that's a great question. We actually got through about 4 control subjects where we repeated the exact same protocol, just instead of the IHH, they were breathing room air, and then COVID hit. And so we have 4 done. I'm starting to kind of go through it just to see. I don't know if that'll give us, the statistical power that we need to make a valid comparison. But as of now, our lab is not fully up and running yet for data collection. And so that has been sort of put on hold because of the pandemic.
Okay, next question. It says, your paradigm involves only a single period of simulated sleep apnea breathing. Maybe this is just not a sufficient stimulus.
Yeah,
Since,
that's exactly. Sorry.
Since patients with sleep apnea have these changes in blood gases over a long period, what do you think would happen if you repeated the stimulus, either for a longer period of time or repeatedly over many days?
That's a great question. And I agree with you. I also feel that, patients with sleep apnea oftentimes don't get diagnosed for a while. So they could be experiencing these obstructions for months, potentially years before they get diagnosed. And 40 minutes just isn't an accurate comparison for that degree of exposure. I would maybe potentially do, a longer exposure. Maybe I know my advisor's done 6 hours before. If we did, overnight or several days, it is possible that we could see differences, but I haven't quite nailed down maybe the mechanisms of what is going on with the OSA patients. So I'm not sure how to predict what stimulus we would need to get close to seeing what we're seeing in a patient population.
Okay, next question. How did you perform PSG and controls, home sleep studies or in lab? And if home testing, what device did you use? Do you think this may have affected your results?
Yeah, so we just had like an overnight, like a wristwatch with a pulse ox, and it certainly isn't as specific as an overnight PSG or even like an apnea link. But we are pretty confident, that there wasn't any sort of underlying disorders. All of our subjects were, healthy and healthy BMI, relatively active, and didn't have any sort of complaints of sleep issues or sleepiness. Blood pressure readings were all normal. So we felt pretty good that we weren't missing anything.
Okay, could you speculate on the mechanism by which the sympathetic response to PICO could be attenuated in patients with sleep apnea?
So my running theory right now is that it might be, if the metaboreflex is in fact impaired in sleep apnea, that maybe there's an over-exaggeration of the mechanoreflex. And there's some evidence to suggest that, in animal work, that angiotensin II mediated oxidative stress could actually sensitize the mechanoreceptors. And so maybe that's contributing to that augmented response during exercise. And then once we remove the influence of the mechanoreflex during PICO, then we see our impaired metaboreflex in action. And so some evidence has suggested that you might need a higher dose of angiotensin II over a longer period of time to mediate these effects, so that's my running theory. If anybody else has ideas, I'll be at my poster, I guess, 4 o'clock Eastern time. And I'd be happy to chat more because I'm also scratching my head at this.
Okay, we have 2 more. One, do you have information on the ventilatory response to PICO?
Oh, gosh, at the top of my head, I can't quite recall. I don't know if we looked at the ventilatory response for us in PICO, and if we did, I'm kind of blanking on what that would be. So I for now, I hate to answer this way, but I'm not sure.
Hey, sometimes it's better to admit you don't know, right?
I'm not going to try to make something up, but I can look at our data before my poster presentation. And again, if you want to come back and chat, I'd be more than happy to.
Okay, last question and we'll move on. Can you measure lactate production pre and post IHH?
Oh, I'm sure we could with a finger prick. Our lab, I don't think has that setup, but the lab across the hall does. So it would be an easy measurement to assess. That would be pretty interesting. Try to tease out, which path, like metabolic pathways are being activated. So good thought. Yeah.
Great. Thanks for answering all the questions.
Great.
And
Thank you.
so just a reminder to the attendees, the next 5 talks are going to be lightning abstract talks, so they're only 5 minutes each. And we will not have questions after each talk. So go ahead and post your questions in the chat or Q&A if you have them then, but we'll answer them at the very end in an open Q&A session.
Great. So our first lightning talk here is Dr. Guillaume Lamotte, and the title of the talk is Sympathetic Noradrenergic Deficiency in Lewy Body Diseases is Cardioselective.
All right, thank you. So my talk is entitled Sympathetic Noradrenergic Deficiency in Lewy Body Diseases is Cardioselective. As you know, Lewy body disorders are a group of diseases characterized by Lewy bodies on pathology and include Parkinson's disease, dementia with Lewy bodies, and pure autonomic failure. In MSA, you can find synuclein, but you usually see a glial cytoplasmic inclusion and not Lewy body. Lewy body disorders are characterized by a cardiac sympathetic deficiency. However, the status of the noradrenergic innervation outside of the heart is completely unknown. So the goal of the study was to assess in vivo and post-mortem noradrenergic innervation in synucleinopathies and control. In vivo, we used fluorodopamine PET scan to look at the heart and also extra cardiac organs such as the liver, spleen, pancreas, stomach, kidneys, thyroid, and submandibular glands. In a largely different cohort, we had data on post-mortem tissue norepinephrine, looking at the same organ of interest except the stomach, and we also had data on sympathetic ganglia. Our hypotheses were that in vivo neuroimaging and post-mortem data would agree in terms of peripheral noradrenergic innervation. Based on what we know from the literature, we would expect to see a decrease noradrenergic innervation in the myocardium in patients with Lewy body disorders. While in MSA, which is classically a preganglionic disorder, we would expect to see normal norepinephrine content in all organs, including the heart. So this was a retrospective study, and we looked at all patients seen at NIH between 1990 to 2020. And in the in vivo cohort included 112 patients with Parkinson's disease, 33 patients with PAF, 85 patients with MSA, and 74 controls. The post-mortem cohort included 38 PD, 2 PAF, 5 MSA, and 35 controls. On the upper right part of the slide, it's an example of a coronal section of a fluorodopamine PET scan in a patient with MSA. You can easily see the fluorodopamine radioactivity in the myocardium, as well as in the liver, head of the pancreas, and stomach. To make sure we were looking at the right organs, we actually superimposed CT imaging and PET imaging. Post-mortem tissue norepinephrine content was assessed by high-performance liquid chromatography. So let's jump to the results now. As expected, cardiac septal fluorodopamine radioactivity was decreased in Lewy body synucleinopathies, so again, Parkinson's disease and PAF compared to MSA and controls. And there was also a decrease in fluorodopamine radioactivity in the submandibular glands in patients with Parkinson's disease compared to control. Interestingly, the liver fluorodopamine radioactivity was higher in synucleinopathies, Lewy body disorders, and MSA compared to control. However, there was no significant difference in the fluorodopamine radioactivity in any of the other organs. Now let's look at the post-mortem cohort. There was a drastic, profound reduction in norepinephrine in the myocardium in Lewy body patient controls, and there was a 97% reduction. However, there was no differences in tissue norepinephrine content in any of the extracardiac organs, as you can see. So this study shows that Lewy body synucleinopathies involve prominent cardiac noradrenergic deficiency by both sympathetic neuroimaging and postmortem neurochemistry. In this study, we validated the use of fluorodopamine cardiac PET scan as a biomarker of noradrenergic innervation in 11 patients where we had both postmortem data and in vivo neuroimaging. There is profound noradrenergic deficiency in cardiac noradrenergic deficiency in Lewy body disorders, but not in MSA, which is consistent with the literature, except very rare cases. And the new finding here is that there is really no evidence of noradrenergic deficiency in extracardiac organs in Lewy body disorders. So what is so special about the heart in Lewy body diseases? Well, the heart relies almost exclusively on aerobic oxidation and might be more sensitive to alteration of mitochondrial function and oxidative stress, for example. So further studies should really investigate the vulnerability of cardiac sympathetic nerve and might provide insight into the vulnerability of other catecholaminergic nerves, such as dopaminergic neurons. Thank you for your attention. I want to thank the autonomic medicine section at NIH, all of the members of the lab, and the patients included in the study.
Thank you, Dr. Lamont, for that talk. And just a reminder, you can post questions in the app, but we'll answer them at the end of this session. So we'll move on now to the next talk.
Our next lightning abstract presentation is from Dr. Christopher Gibbons, and it's entitled Cutaneous Alpha-Synuclein Deposition Across the Synucleinopathies.
Hello, everyone. Nice to see you by Zoom. I'm sorry we're not all in Hawaii together, but thank you for the opportunity to present our work. I'd like to acknowledge our funding sources and, of course, our disclosures as well. So as background, many of us, and you've heard us talk about this for some time, that phosphorylated alpha-synuclein can be detected within cutaneous autonomic nerve fibers of patients with Parkinson's disease and multiple system atrophy. Now, our objective in this particular study was to define the cutaneous deposition of phosphorylated alpha-synuclein across all of the synucleinopathies, not just Parkinson's, MSA, but including DLB and pure autonomic failure. So we recruited a total of 109 individuals with synucleinopathy and 96 control subjects across a number of institutions. These included 21 individuals with MSA, 51 with Parkinson's disease, 19 with DLB, 18 with PAF, 61 healthy control subjects, and 35 disease control subjects that included neuropathy, essential tremor, Alzheimer's disease, and stroke. All individuals had 3mm punch biopsies taken from the distal leg, the distal thigh, and the posterior cervical region. These skin biopsies were dual immunostained for protein gene product 9.5, which is a pan-axonal marker, and phosphorylated alpha-synuclein, and then we quantified these results. I'm going to jump into the results section because I think that's by far and away the most interesting stuff. So just first of all, what we're looking at when we talk about immunohistochemical staining. So on the top right of your screen, you're seeing a rotating image of nerve fibers. And on the right portion of that screen, for those of you who are not colorblind, that's green. I apologize to those of you who are. This is a nerve fiber. And what we're seeing is the corresponding phosphorylated alpha-synuclein within the nerve fiber. And we're specifically interested in intraaxonal evidence of phosphorylated alpha-synuclein, and you can see this co-localizes perfectly. And then if I bring your attention over to the left side of the screen, these are the results of the overall study. So by disease, Parkinson's, MSA, DLB, and PAF, and then the controls. You can see the distribution by sex and age. Hone and Yar stage, of course, a 0 to 4 scale, 0 being no disease, 4 being, severe bedbound, advanced disease. Cognition. And then really what we're looking at in the data here is the phosphorylated synuclein positive individuals, and then the percentage. So what you can see in Parkinson's, 96% of these had evidence of phosphorylated alpha-synuclein on biopsy, 100% of the MSA and DLB, and 94% of the PAF. Whereas none of the healthy control or disease control subjects had any evidence of phosphorylated alpha-synuclein on skin biopsy. Now, as a test characteristic, if we group all of these synucleinopathies together and compare these to the control subjects, what we get is a sensitivity of 97%, a specificity of 100%, positive predictive value of 100, and negative predictive value of 97, with an accuracy of 98.5. Now, I want to highlight most significantly is the data down here on the bottom right. So you can see the individual subjects down here, and this is the quantitative assessment of phosphorylated alpha-synuclein. And what you see is down here with MSA, it actually has the least deposition of phosphorylated alpha-synuclein. Parkinson's was intermediate and DLB was the highest, whereas pure autonomic failure, as anticipated as a synucleinopathy that may morph into any of these, spread across these different groups entirely. The control subjects had no evidence of phosphorylated alpha-synuclein deposition. So we report the largest study of cutaneous phosphorylated alpha-synuclein. Skin biopsy exhibits high sensitivity and specificity using a binary diagnostic outcome measure, which was either the presence or absence of synuclein. At present, the capacity to pathologically differentiate between synucleinopathies is not established, although our results suggest it may be feasible. Ongoing investigations are in process to define the relationship between the quantitation of phosphorylated alpha-synuclein, clinical examination scores, disease progression, and really expand the utility of phosphorylated alpha-synuclein testing. These data suggest that the assessment of cutaneous alpha-synuclein deposition may show promise as a diagnostic, prognostic, and therapeutic biomarker, and has implications for clinical trials of disease-modifying therapeutic interventions to treat the synucleinopathies. Of course, I'd like to acknowledge my collaborators on the projects, and please come to virtual poster number 2 for additional details. Thank you very much for your attention. And stop sharing there.
Great, thank you so much for that talk. So we'll move on to the next talk now. It's Dr. Wolfgang Singer. And the title of the talk is Alpha-Synuclein Oligomers and Neurofilament Light Chain in Spinal Fluid Differentiate Multiple System Atrophy from Lewy Body Synucleinopathies. And Dr. Singer, I think you're still muted.
Sorry, I had some technical difficulties. This is another approach at biomarkers in synucleinopathies. And as you all know, Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy all share the pathophysiological mechanism of abnormal aggregation of alpha-synuclein. Misdiagnosis is still quite common among those conditions, particularly when we look at early disease stages or atypical presentations. And there clearly is a need for reliable biomarkers to solidify the diagnosis under those circumstances. There is a couple of rather exciting spinal fluid markers that have recently been reported that might fill that gap. One of them is neurofilament light chain, which is a marker of central axonal degeneration and has been reported to be elevated, significantly so, in neurologic conditions with rapid disease progression that includes MSA. We also recently showed that the misfolded form of alpha-synuclein can be reliably detected in the spinal fluid of patients with MSA and Parkinson's disease using a protein misfolding cyclic amplification, or PMCA technique. And we've also shown that the product of this assay is actually disease-specific. We now wanted to confirm the value of these markers as diagnostic biomarkers differentiating MSA from Lewy body synucleinopathies in a prospective fashion. So in a discovery phase, we looked at prospectively collected spinal fluid from patients with multiple system atrophy and normal controls. And then in a confirmatory phase, looked beyond MSA and controls, also at patients with Parkinson's disease and dementia with Lewy bodies. Characterization of participants is as listed here. All patients were enrolled as part of a prospective longitudinal study of synucleinopathies and dementias at Mayo Clinic Rochester. And all disease categories were categorized by, characterized by early disease stage. For the case of multiple system atrophy, for example, a AMSAS-1 score of 17 or less was required. We studied these patients clinically, with MRI, with autonomic testing, and also by obtaining spinal fluid, specifically testing for neurofilament light chain, as well as alpha-synuclein oligomer versus PMCA, taking advantage of the prion-like propagation of misfolding of alpha-synuclein. We enrolled a total of 120 subjects, and as far as the alpha-synuclein PMCA assay is concerned, we could demonstrate that indeed the reaction was positive in all patients with MSA in our discovery cohort and non-reactive in all controls, perfectly separating those two groups. In our confirmatory cohort, we could again show a very similar findings, although 2 MSA samples remained non-reactive. And when we looked at patients with Parkinson's disease and dementia with Lewy bodies, we again saw positivity in all but 2 cases. And patients with PD and DLB were characterized by a much greater magnitude of amplification than was seen in the MSA group, ultimately allowing us to not only differentiate MSA from controls, but also MSA from the Lewy body synucleinopathies. On the right bottom panel, you see the difference in the reaction kinetics in the groups. MSA is the group that shows an early reaction, but low plateau. In Parkinson's disease and dementia with Lewy bodies, a late reaction, but much higher reaction plateau. Our data for NFL show, not surprisingly, that MSA patients had elevated levels, perfectly separating them from normal controls. And patients with Parkinson's disease and dementia with Lewy bodies all remained, or for the most part, remained within the range of normal controls. To highlight the diagnostic value of these markers, we obtained ROC curves. Left panel shows NFL, right panel shows alpha-synuclein oligomers. Top panel show differentiation of MSA from controls, and bottom panel differentiating of MSA from Parkinson's disease and dementia with Lewy bodies. When we combine those markers, we have 100% sensitivity and specificity for separating MSA from controls, and 97% sensitivity and 100% specificity for differentiating MSA from the Lewy body synucleinopathies. With that, we can conclude that these 2 markers faithfully differentiate early MSA not only from normal controls, but also from Lewy body synucleinopathies, and that these markers indeed seem to possess great diagnostic value and are basically ready for clinical implementation. And our findings have furthermore implications for our understanding of protein misfolding and alpha-synuclein misfolding in general, beyond the diagnostic value of these markers.
Thank you so much for that presentation. We're going to move on to lightning round presentation number 4, and it's entitled The Effect of Analgesic Fentanyl Administration on Sympathetic and Cardiovascular Responses in Humans During Simulated Hemorrhage, and it will be presented by Dr. Joseph Watso.
Hi, thank you for the invitation to speak here today, and thank you for the introduction. So to get right into it, we know that hemorrhage is a leading cause of preventable death in battlefield settings and also in civilian pre-hospital settings. And there are several pain treatment options that can be used, one of which is fentanyl. So fentanyl is a commonly used pain medication, and in the field setting following a hemorrhagic event, when there's pain present, specifically moderate to severe pain, this is recommended to be given to individuals if they're not in or at high risk for circulatory shock or respiratory depression or distress. And this is because of data in anesthetized animals suggesting that fentanyl elicits cardiorespiratory depression and also elicits hypotension. However, the data for this in the context of hemorrhage in humans is lacking. So the purpose of our study was to determine if fentanyl has a negative impact on hemorrhagic tolerance and if it elicits negative impacts on the sympathetic and cardiovascular responses associated with hemorrhage. So the purpose of our study was to test the hypothesis that fentanyl administration in conscious humans impairs tolerance to a simulated hemorrhagic insult. And we hypothesized further that this would occur via withdrawal of the sympathetic nervous system and reduced cardiovascular compensation. So our experimental protocol consisted of a randomized crossover placebo-controlled design, and we used lower body negative pressure as a stimulus to elicit or simulate hemorrhage in the laboratory setting. So you can see the little cartoon image of an individual who we had supine and sealed in an airtight chamber at the waist. And we turned on the vacuum to essentially pull air out and reduce the pressure in that chamber to minus 40 millimeters of mercury, 1 minute following administration of drug or placebo. And every 3 minutes, we reduce that further by another 10 millimeters of mercury, up to a maximum of minus 100. And we stop the test when an individual displayed signs of presyncope. So here you can see nice representative tracings from a placebo and fentanyl visit that were completed on 2 separate days in the laboratory. And the representative blood pressure tracings, you can appreciate the precipitous drop in blood pressure that occurred at the termination of those tests. And before I move on to orient you to the time points I'll be presenting on, we have 40, 50, and 60 as the stages. We looked at the final minute of each stage, and then also the final 20 seconds, regardless of when an individual stopped the test. So this data includes 22 young military age adults. And first we have our survival plot. So to orient you, the cumulative stress index takes into account not just the time, but also the pressure that the individual sustained. So it could be a more sensitive marker. In any case, you can see the survival curves between fentanyl and placebo were not different. And if you were to do a simple paired t-test of the tolerance times, this was also consistent with no difference between the two conditions. As for our sympathetic responses, as expected, MSNA burst frequency increased throughout the LBNP challenge. However, there is no difference between placebo in the gray bar and fentanyl in the blue bar. Likewise, for blood pressure, there is an expected reduction throughout testing. However, again, no difference between conditions. So from these data, primary findings were that fentanyl does not impair hemorrhagic tolerance or sympathetic and cardiovascular responses associated with hemorrhage. So to conclude, our experimental preliminary data do not support the US Army guidelines for pain management in the field because we did not find evidence of fentanyl negatively impacting tolerance to profound central hypovolemia in healthy conscious humans. With that, thank you for your attention.
Thank you for that talk. And we'll now move on to lightning abstract presentation number 5. This will be presented by Samya Kulkarni, and the title of the talk is Activation of the Rostral Ventrolateral Medulla Results in Differential Increases in Adrenal versus Splanchnic Sympathetic Nerve Activity.
Yeah, thank you for that introduction. And I'm really excited to have the opportunity to talk here today. So I'm going to try and share my screen. Sorry. Okay. So I'm an undergraduate at the University of Michigan, and today I want to talk to you about some work I was involved in at Wayne State University, where we looked at the dual roles of the rostral ventrolateral medulla in blood pressure regulation, as well as blood glucose regulation via increase of plasma epinephrine release from the adrenal medulla. Knowing kind of these dual roles of blood pressure control and glucose control of the RVLM, we were interested in seeing first whether there would be any anatomical basis for differential regulation of the adrenal versus splanchnic sympathetic nerves. And next, we were interested in seeing whether there might be a neurotransmitter mechanism basis for differential control of these two nerves. Our hypothesis was that given the diverse physiological functions of these two nerves, the RVLM employs differential mechanisms to facilitate regulation of the adrenal versus the splanchnic sympathetic nerve. So these are the methods we use to measure blood pressure in male Sprague-Dawley rats with catheters and perform microinjection experiments with micropipettes, and then measure the adrenal and splanchnic sympathetic nerve activity using silver hook recording electrodes. So for our first set of experimental protocols, we injected our glutamate into the RVLM ipsilaterally and contralaterally. So to orient everyone to this figure, we're looking at a sagittal section of the brain and the brainstem. And so when we injected glutamate into the RVLM, we saw the expected increases in both adrenal and splanchnic nerve activity. Our second set of experimental conditions, we dropped the blood pressure by giving sodium nitroprusside, first in the absence and then in the presence of a bilateral GABA-A receptor blockade of bicuculin. So when we dropped the blood pressure, we expected that the input from the baroreceptors onto the NTS would decrease. This in turn would decrease excitatory input from the NTS onto the CVLM. This would decrease inhibitory input from the CVLM onto the RVLM. And this would raise the sympathetic nerve activity that was being controlled by the RVLM. We then gave an injection of bicuculin to block the GABA-A receptors, and we dropped blood pressure one more time by giving the sodium nitroprusside. So when we gave our glutamate injection into the left RVLM, this was our ipsilateral condition because we were injecting into the left side as we recorded nerves from the left side. And we saw an increase in both splanchnic and adrenal sympathetic nerve activity as we expected. And then when we gave glutamate in our contralateral condition, where we gave glutamate on the right side and continued to record from the left side, we saw similar increases in the splanchnic nerves, whereas we saw much less increase in adrenal sympathetic nerve activity. This led us to conclude that potentially the adrenal nerve has predominantly ipsilateral innervation from the RVLM, whereas the splanchnic nerve has similar innervation from the left and right sides. We then proceeded to do a set of experiments where we dropped the blood pressure by giving sodium nitroprusside. And after this produced a drop in blood pressure, we gave our bilateral GABA-A receptor blockade, and we dropped the pressure one more time. And when we dropped the blood pressure the first time, we saw an increase in both splanchnic and adrenal sympathetic nerve activity. But if GABA-A mechanisms are responsible for kind of this increase in nerve activity, we would expect that when we block these receptors, we wouldn't see that increase anymore, which is what we saw with the splanchnic nerves, but not with the adrenal nerves. The adrenal nerves had similar levels of activity both before and after bicuculin injection. So this led us to believe that potentially baroreflex mediated changes in adrenal sympathetic nerve activity are not mediated by GABAergic mechanisms. So our conclusions are that the RVLM has predominantly ipsilateral innervation of adrenal nerves, and that baroreflex mediated increases in the splanchnic sympathetic nerve activity, but not the adrenal sympathetic nerve activity, are mediated by GABA in the RVLM. This raises questions about the role of epinephrine and glucose homeostasis in the body, which we probe a little bit further in our virtual poster number 19. So please come see us then. And thank you to the American Autonomic Society for the opportunity to present today.
Okay, and thank you for your talk. So we'll move into the questions now, and we're just going to go through in speaker order with some of the questions that have been submitted. So we'll start here with Dr. Lamotte, and the first question is, given that there is selectivity of abnormality of cardiac innervation, does it make sense to assess synucleinopathy subtypes from skin biopsies?
Yeah, that's a very good question. I think from the skin standpoint, I think about looking at synuclein in the skin more as a biomarker perspective. And if you look at the sympathetic nerve in the heart, it can be a biomarker as we saw from the neuroimaging standpoint, but I think there is clear evidence that it's associated with denervation and it then provide more an insight into the pathogenesis. However, I would not throw the skin out of the way because meta-analysis and have shown very good pooled sensitivity and specificity as a biomarker of synucleinopathies. However, does it give us any insight into the pathogenesis of the process? I don't think we have any data, and I'm just waiting to be convinced about that.
Okay, thank you. And then one more question as well. So regarding noradrenergic dysfunction specificity of the heart, why would the metabolic state of the heart affect the sensitivity of the cardiac adrenergic nerves?
Yeah, so that's a question that I would more relate to the proposed pathogenesis or pathophysiology involved in these Lewy body disorders. And if we take Parkinson's disease, for example, mitochondrial dysfunction, oxidative stress, both have been really, suggested as being involved in the pathogenesis of this disorder. So because the heart relies on function, you could imagine that the sympathetic nerve, specifically the cardiac sympathetic nerve, might be more sensitive to mitochondrial dysfunction. Another point that I would like to make is, unlike any other organs in the body, about 80% of the norepinephrine in coronary arterial plasma is actually removed in the plasma, in the passage through the heart. So if you could imagine that an initial insult, that, for example, a circulating neurotoxin that would be specific to the sympathetic nerve, clearly you might have, you will have a greater damage to sympathetic nerve in the heart than in any of the other organs.
Okay, thank you. And I think we'll move on now to Dr. Arnold with some questions.
So we have a couple that rolled in for Dr. Gibbons. The first is any skin biopsy data for REM behavior disorder?
Yes, there's actually quite a bit of data, some of which has been published already. Mitch Miglis, who's somewhere in the Zoom call out here, has some very interesting data that he's working on with us as well. But in general, RBD is positive approximately 70% of the time without any clinically apparent synuclein features, kind of an overt synucleinopathy, so pure RBD.
And Chris, real quick, Chris, is it a wide range of like in PAF?
So I don't know that we have enough data to answer that question. That is our hypothesis going into that, yes, but we do not have enough data to demonstrate that yet.
Sorry for the interruption.
Oh, no, you're fine. Interrupt away. The next question was, does it matter where on the skin you take the biopsy? Any place okay? And are those kits that are being promoted acceptable, or do they have to be sent to an expert center?
So the skin, the choice of selection, it absolutely makes a difference. So there is a length dependent component to damage to the nervous system. And so this relates to the prior questions that were raised as well. So if you do a proximal biopsy site, for example, the posterior cervical region, you tend not to see any evidence of a length dependent axonal damage process, particularly as it relates to, say, sympathetic adrenergic fibers. But if you do a distal leg biopsy as well, you can see that metabolic impact on the nervous system, and you will see definite dropout of sympathetic adrenergic fibers distally. But we do select 3 sites specifically to maximize our potential diagnostic sensitivity.
Great. And I think Kate has a question for Dr. Singer.
Yes, so the next question here is, I suspect that biomarker studies are done in patients with a virtual definitive diagnosis of MSA and LB. What is known in patients with early disease in whom the markers would be most useful?
Yeah, it's a very good question. In fact, it was the specific purpose of this prospective study to enroll patients at as early stage as possible, as soon as we had clinical confidence that that was the diagnosis, and we then followed them longitudinally to confirm that. So this is an early disease stage that we're looking at here. And of course, a big interest is in expanding these markers now into even earlier disease stages, into the premotor or even prodromal stages, and that's work in progress.
Okay, thank you. We have 3 questions for Dr. Watso. He's still on. Sure you didn't disappear.
Yeah.
So the first is, have you considered blocking opioid receptors with naloxone, for example?
Interesting. So we did not. Our funding body, the U.S. Army, was most interested in what's used in the battlefield. So those are generally pain-reducing medications. But as far as naloxone and hemorrhagic tolerance, I think there are a few articles demonstrating that naloxone actually decreases tolerance to hemorrhage and causes some modest changes with cardiopulmonary baroreflex sensitivity.
Okay, next question. Do you have heart rate or cardiac output data for the simulated hemorrhage?
Yeah, great question. We do. The results were similar to the blood pressure in that heart rate increased and cardiac output increased to an extent before dropping off at the end, but again, no difference between the fentanyl or placebo experimental visits.
And then last question, since military are physically well trained, do you think that exercise affects these responses?
Could be. I think in the context of our study specifically, it's within design. So each individual served as their own control against placebo. But that is something that we could potentially investigate, thinking about the endogenous opioid systems and how those might be affected by exercise training. That's something we've thought about and something that we'll look into as we build our data set.
Great. Let's see, we have a comment from Dr. Gibbons to Ben Levine's question. He said, we collaborate with only one group to do this with prepared kits, and that is reliable. Not aware of any other groups doing this. And we have a comment from Dr. Goldstein. Just in general, I think the heart stands out from all other organs in the high rate of oxidative metabolism of catecholamine. So I think that's all the questions that we had come in. If there's any last minute chat or Q&A, go ahead and ask them real quick. And otherwise we can close out this session. Okay, I don't see anything else rolling in. So thank you to all the speakers and to all the attendees for joining us today. We really appreciated it. Please give us feedback on how you liked the lightning round talks. And please visit our sponsors and exhibitors as well as the poster sessions following the meeting. Thank you.